Good afternoon, everyone, and welcome to our Protect Our Province COVID-19 briefing for Wednesday, December 1st, 2021. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is being shared in ASL. To ensure access to completely accurate information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, Twitter, and Facebook. The Protect Our Province COVID-19 briefing is a regular panel of doctors and experts. We will endeavour to bring you timely, accurate updates on the COVID-19 situation in Alberta and take questions from the public and the media. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans, attempting to ensure that everyone in the province has access to as much information concerning COVID-19 in Alberta as possible. As always, we will start things off with an update on the COVID-19 situation in our province. And with us today for that update is Dr. Vipond. Dr. Vipond, welcome back and congratulations on regaining your Twitter.
Yeah, such a weird situation. I'm not going to get into it because they have more important things to deal with today. So let's just go right into the slides and just start talking about what we see in Alberta. So this is today's data. We have cases per day of 435. I haven't had a chance to calculate everything because things were put online a little bit late by the government. So 435 today, last week 475. That's a little bit less than 10% drop week over week. And it's been a drop for the last 4 or 5 days. So that's been very good because there was a period of time about a week ago where things were very flat. It was very plateauing, but we've re-found our descending curve, which is really great. Next slide, please. And you can see that here where we have that really flat section, and then it's not hard to tell, but there is definitely a decrease in this last week period. And the 7-day average right now is 320. And that's down from the 7-day average last week at this time of 376. So a little bit over, somewhere around 20%. Next slide, please. This is the positivity. We've got a 4.07 today and 4.58 last week. Again, you can see how it was really, really flat for a long period of time, even a little bit of an increase about a week ago, and then now solidly in the decline, which is, again, reassuring. Next slide, please. And, sorry, guys, these are out of order. Let's just see, go to the slide beyond that. We might come back to that one. Yeah, okay, so this is our hospitalizations. I don't have the numbers in front of me, but a very, very, very slow decline going on in our inpatients, and then down 2 in the ICUs, again, dropping, but very slowly, much slower than past curves. Next slide, please. And you can see this is the overall wave 4 hospitalizations in ICUs. Next slide, please. And this is the demographics. This is per 100,000 population. So this shows the rate of cases. And, you know, I like to show this every time because it just reinforces the fact that right now this is a kids pandemic, right? Those 5 to 11s are the ones that are suffering the brunt right now. And I don't know if everybody's kind of recognized that really we're not going to have full protection of these kids for 10 weeks because they just started on Friday. It takes 2 doses, 8 weeks apart, plus 2 weeks in order to get that full protection of the double dose. So we're looking at 10 weeks from now, and we still have a situation where the kids are dominating this. There are such simple things we can be doing to protecting them. We can remove all the mask exemptions. Those max exemptions we could remove would be the fact that K to 3 are exempted around the province. There's some school boards accepting. There's also an exemption if you're sitting at your desk facing forward. You can take off your mask. That's ridiculous for an airborne transmitted virus. And there's also exceptions for extracurricular activities and sports. You know, if we got rid of all of those exemptions, the kids would be so much safer and we wouldn't have this domination by them. We can reinforce our test, trace, and isolate system. We can instill serial rapid testing, especially in schools where there's transmission. And I know there is a little bit of that, but we could do so much better. And finally, we could just get as many vaccines in as many arms as possible as soon as possible. So I'm hoping that the government takes some of those things to heart. Next slide, please. So yeah, let's bring that up. So this is some of the data that I've been seeing over the last couple of days that's got me worried. So this is on the left, we have the daily cases for the Omicron. You can see how incredibly steep that rise is. It is crazy. I'm going to bring up the actual data. This is for all of, this is for Gauteng province. And then you can see the weekly shares that have tested positive. They're already at around 16%. And then hospital admissions, I don't know. You hear these statements put out by the WHO and others that this is a less virulent virus. I don't know what they're basing that on because I'm not seeing it in the numbers. In fact, if you can go back a few slides, Chad, you'll see that one slide that was stuck in there. So this is the Gauteng province hospital admissions. You can see it just starting to curve up, but you can see how rapid that jump is from 103 to 136 week over week. That's a 30% increase. There's nowhere on this curve anywhere that has a 30% jump except for that 2-week period. And so let's go forward again to the next slide. There we go. So this is looking at the entirety of South Africa, all of the provinces, and Gauteng is the one where it started. And so I guess there was this maybe hope that it would be restricted to that, but you can see that every single province in South Africa is now on the upswing. And I don't want to single out South Africa as some kind of horrible place. I think the thing that we're seeing is South Africa has so much better data than all the other sub-Saharan African countries. We have no idea what's going on in other countries. And it's only thanks to the good healthcare system in South Africa that we even know any of this data. Next slide, please. And boy, I sure want to get our panelists' take on this. This is a slide that was released on Monday by the South African government for the Tshwa Metro Hospital, which is in Pretoria, which is one of the major hospitals in Gauteng province. And it seems to suggest really bad virulence of look at the 80 plus, where 60% approximately of cases have ended up in hospital, and the kids 0 to 4. Huge number. So I hope that this is wrong and that there's something about the data for this that is inaccurate. But this is the first slide that I've seen that really looks at the virulence, and it's not reassuring. So I'm just going to quickly just read off something for the whole country as a whole. So today, South Africa reported 8,500 cases. That was up 571% from last week, including 40% increased testing. But yesterday, I've got today the percent positivity was 16.5%, which is way up from last week as well. So we can't say that all these increased cases are due to increased testing. This is also spread as seen by that increased positivity. So something's going on. I don't know. I don't like it. And I guess the last thing I'll say is some of the things I've seen on Twitter. There's an article in the Sydney Morning Herald from Australia that was out today saying that Omicron could be God's gift to humanity and that it's less virulent and more transmissible. Maybe it'll rip through us and we'll all get immunized and all will be well. I do have one more slide, Chad. If you could just pull that up. I think it's the last one there. So the problem is that, well, there's two problems. First of all, we have no idea of the virulence of this. We don't even know of the increased transmissibility of this virus because we're so early. I want to remind people that we're on day 7 of knowing about this variant, day 7. And so we don't know a lot. And hospitalizations and deaths are lagging indicators. They follow the cases. They don't go along with the cases. So we're still learning about this. We're going to know a lot more in 2 weeks. But let's just say that we have I have to decide whether we want a virus that's the same lethality as Delta, and or decide between sorry, let me go back this again. We have to decide whether we want a variant with the same lethality but 50% more transmissible, or we want to have a variant that's 50% more deadly but the same transmissibility. And the answer to what you want is you want to have a more lethal virus, and that's counterintuitive. We always think, well, we want to have at least the transmissibility is not the big deal, it's lethality. But because of exponential growth, and you can see that in this graph, if it's more transmissible, even with the same lethality, you're going to have way more deaths from that virus. And all indications say that this is more transmissible, and we do not know the virulence. So I do not want Omicron on my planet, and I'm really quite angry and sad that we have to deal with this. And I think I'll leave it at that.
Thank you very much, Dr. Vipond. As we keep diving into this conversation around Omicron variants, transmissibility, I would love to bring the rest of our panelists onto the screen so they can introduce themselves. So everybody watching at home and any media present will have the opportunity to formulate some questions based on the expertise of the panel that we have with us. So let's bring everybody up. And if we could just go around the circles-ish squares, the square circles, starting with Dr. Kindrachuk. Hi, thank you for joining us.
Hi. Thank you for having me. I'm Dr. Jason Kindrachuk. I'm a PhD, so not a real doctor. Listen, I'm a moderately adequate virologist that somehow has found himself kind of involved in in outbreak response and working with really bad viruses for a number of years now. My research lab primarily works on Ebola. I've been involved in Ebola research outbreak response in the past. My research program centers around Ebola, but we also work on influenza and coronaviruses, and certainly have spent quite a few years working in high containment labs and beyond, specifically on viruses like SARS-CoV-2. So, since the emergence of this virus, I've been heavily involved from a research standpoint, from a public messaging standpoint. Spent a year in Saskatoon, seconded to be able to provide additional research support for efforts in Canada, and am also a member of COVARNet, the Coronavirus Variants Rapid Response Network here in Canada, that really is geared to trying to address emerging variants and how we try and combat these in real time. So it's a pleasure to be here, and looking forward to provide what context I can.
Thank you so very much for joining us. And another first-timer with us today is Dr. Kelvin. Dr. Kelvin, if you could introduce yourself.
Hi, everyone. I am Alyson Kelvin. I'm also a PhD like Jason, and a good friend of Jason's. I'm sure he's happy to get more time with me. I'm also a virologist as well as an immunologist and vaccinologist. I mush those two together and to call it vaccinology, because you have to have an understanding of the virus as well as the immune response to formulate a protective vaccine. So previously, I've worked on many different emerging viruses with a specialization in emerging respiratory viruses, such as SARS-1, as well as many different influenza viruses. So I felt ready to take on this new coronavirus when it first emerged in 2020. So I'm here to, I guess, share my knowledge, and I'd be happy to take questions.
Thank you so very much, Dr. Kelvin. Dr. Gasperowicz, as a returning regular contributor to PopAB and a member of our core team, just in case there's anyone joining us for the first time, if you could give a brief overview of yourself as well, that would be great.
Hi, everybody. Good afternoon. My name is Gosia Gasperowicz. I'm developmental biologist, and I would argue that as PhD, I'm a real doctor. But and so I'm developmental biologist since, I don't want to age myself, but many years. I observe different dynamic biological processes, from kinetics of enzymes binding through how the embryo and placenta is developing, or how just cells grow on petri dishes, how fast they do it or how slow they do it, depending on what we treat them with. So how fast we can kill them and how fast we can make them flourish. So I started observing the spread of SARS-2 in February 2020. So since February 2020, I'm looking at the dynamics of its growth or decline in different jurisdictions and making projections too. Thank you.
We're going to start our deep dive of conversation off today with a presentation by Dr. Gasperowicz. Now, before we go into that, Dr. Kelvin or Dr. Kindrachuk, is there anything that you wanted to offer right off the top, as Dr. Vipond had solicited your feedback based on his thoughts before we move into that next phase of our dive? Well, it's fresh in your minds.
Definitely. So one of the things that I think we need to kind of keep in mind here is, listen, this situation is very, very fluid, right? So right now, the data is certainly noisy, and I mean that in the context that we don't have a specific measure right now of what we're seeing in regards to virulence and transmissibility. And I think Dr. Trevor Bedford had a really great thread on this today as he's been trying to go through and calculate what we're seeing right now in regards to transmissibility with Omicron. There is some very wide confidence intervals on the data. We have to appreciate that the case numbers, certainly of Omicron confirmed cases, have actually not been that exceedingly high. So that makes it a little bit more difficult to say specifically what's going on. And what I can say from a research standpoint, it's going to take us certainly a few weeks to really address these questions. We are waiting for virus isolates. We certainly have to all get every moved across the globe and work with collaborators across the globe to identify what assays need to be done. Many of us have been on calls 24/7 the last few days about this. So I would again say that we need to be very cautious in the interpretation of the data. We certainly have to appreciate Delta is still moving through the community. We have to keep that as a focal point. Omicron is concerning, but we don't specifically know what we're dealing with yet. But we do know that the measures that we're using can help reduce transmission. So get vaccinated, or additional public health measures or recommendations. We have to follow those along with good testing. And I think the next few days are going to be very loud with a lot of cases being identified. But that also harkens back to how quickly we've been able to identify this new variant and been able to get good testing strategies moved across the globe.
Dr. Kelvin, did you have any initial thoughts that you wanted to share before we go into Dr. Gasperowicz's presentation?
I think Jason took all of the good ones. I very much echo everything that Jason said. I think it's really important to recognize that we're quite early in this, the discovery of this new variant, and there's several different lines of investigation that need to be taken before we can really come to conclusions about it. I also want to point out that, and Jason mentioned this, the fluidity of each situation and how dynamic this is. Looking back on the past 3 waves that South Africa had, this, was a different place in time than where we are right now. So I think we need to take a step back and look at the data.
Thank you both very much for your initial thoughts on that. I'm going to turn things over to Dr. Gasperowicz, and I'm going to pop everybody back into our backstage area. Thank you, Dr. Gasperowicz, for preparing a starting point for today's topic.
Thank you very much. So, yeah, I would like to show several slides. So starting, okay. So here is the slide showing just sort of theoretically what we can, what different variants do that are more and less transmissible. So if now we have Delta in Canada, that is the dominant variant. And more or less now we are oscillating around RT equal 1. So one person infects another one person, basically. So it's sometimes it's going a little bit up, sometimes a little bit down, but in Canada, very often we are at RT1 of Delta. And what is important here, that if we wouldn't allow a year ago or 1.5 years ago, if you wouldn't decide that it's okay to spread the virus then Delta wouldn't, the Alpha wouldn't emerge and Delta wouldn't emerge. If we would stay at original variant or even at Alpha, then already in many places we would stop we would be able, with vaccines that we have and with some public health measures, to stop the community transmission quite easily. So what gives for Delta now R equals 1 would be for Alpha, so B117, it would be RT equal 0.7, and for original strain, it would be R 0.5. So I still think it's really grave mistake what we did, that we let it spread, because spread is everything. And we're still letting it spread. So it's really a pity that a year or year and a half ago, we didn't decide to maximally suppress the virus until we have vaccines. Next slide, please. And here, coming to Omicron. So we don't know how much bigger fitness or how much better it transmits compared to Delta. So again, I make a theoretical thing here. Just if we would have a variant which growth rate would be 50% more bigger than Delta, and the growth rate could be faster because of vaccine evasion, immune evasion, and because of intrinsic higher transmissibility. But anyway, if it would be 50% more transmissible, then we could have situation like on the left side of the graph. So if our delta RT currently would be 0.9, so slowly going down from 200 cases, and we would have 10 cases already rooted in a community of new variant that is 50% more transmissible effectively, then its RT value would be 135, so it would be growing exponentially quite fast. But so basically, if the Omicron would be 50% more transmissible effectively, then to stop something like this from spreading, to like nip it in, like prevent it from establishing, we would need to bring delta RT of delta to 0.6. Then the new variant would have RT of 0.9 under such conditions, and starting from 10 cases, it would be slowly decaying. Next slide, please. And here, sorry, it's a very busy graph, but I just wanted to come back to the past when we first had a first new variant of concern that is Alpha B117, also called B117 or UK variant, and what happened in Alberta in winter last year. So there's linear scale on the top graph and logarithmic scale on the bottom graph. So we let it really spread for very, very, very long time before we acted. And to come back, already we had the first case on December 15th last year. And it's important to note that not all imported cases will start the spread, and that's what happened. So we still have chance to be not in the worst case scenario with those few first cases, but eventually some of the cases would sort of take roots and spread in the community. And that happened, we already seen on January 25th that Alpha was spreading in community. So it was spreading at least for 1 or 2 weeks before. And already in February, March, and April, we had clear exponential growth, which you can see on the bottom graph, which is logarithmic scale. And that's the scale we should always use evaluating the spread of this virus, because it grows exponentially or declines exponentially. So something that looks very flat on the top graph, on the bottom we can see that actually it was exponential growth and it was totally ignored. And we didn't took appropriate measures before it would really burst into this huge wave. So I hope that we won't repeat the same mistake with the Omicron, and we will try to really quench it at the very, very early moment, like what we would do with cancer, for example, right? So next slide, please. And here, coming again to the spread, because in the same way that variants don't come by themselves, they come because we let virus spread, replicate many times, and try the best way, try to be better. So it tries to be better and becomes nasty variants evolves into nasty variants. Also, by letting virus spread, we generate waves. And here's the difference between approach of Atlantic Canada with elimination strategy and the rest of the Canada with mitigation strategy. So here in Alberta, we had already 4 large waves. At the same time, Atlantic Canada decided to stop community transmission and then fight the outbreaks if they appear, had much better outcomes in terms of cases. So they had some outbreaks during our 2nd and 3rd wave. But what is interesting that because of the travel control, so the mandatory quarantine between provinces, those outbreaks didn't spill to neighboring provinces. So if the outbreak was in Nova Scotia, it didn't spread to Prince Edward Island or New Brunswick. What is also interesting in this is that sometime in summer, New Brunswick decided to live with COVID, so adopted mitigation strategy and dropped the elimination strategy. And we can clearly see it on the graph that their cases are going up much faster and to much higher levels than in the rest of the Atlantic Canada. Next slide, please. And that translates, so here this graph shows new deaths per 100,000 people. So it's adjusted for population, like the previous graph was adjusted for population too. And we see that there was much more deaths in provinces that let the COVID spread than in the provinces that wanted to stop and actually stop the community transmission. And now we can also see that in New Brunswick, the death rate is very similar as in other provinces, like in the non-elimination provinces. Next slide, please. So basically, policy is up to the government. Like we cannot, the government can do policy that will prevent 5th wave or will cause the 5th wave. So here we don't have much power, but we can protect ourselves, and we can protect our loved ones, and we can make our holidays safer. So there are simple things that we can do. There are airborne precautions, vaccinations, and rapid tests. So we know that COVID is airborne, so we can ventilate, we can use CO2 monitor to assess ventilation quality in real time. So if the reading is more than 1,000 parts per million, it's not good, we should open the window. We can filtrate air using portable HEPA air purifiers and use as good masks as we can. So we should use respirators, KN95 and higher. There's a lot of those produced in Canada. Some are cheaper than $2 per or $1.70 per respirator. So they're not super cheap, but for most people they are probably affordable. And we should use them every time we are in enclosed spaces with other people, or in enclosed spaces where there were other people, so in places where there can be aerosols that carry the virus. Also, we should vaccinate as soon as possible. We are eligible for the 3rd dose. We should get them and vaccinate kids and use rapid tests. That's an amazing thing. Like before family gatherings, we should really, if we can, get those rapid tests and test family members to prevent asymptomatic spread, to catch if anybody is infected, then we can detect, not 100%, but that those tests can help us detect somebody who is asymptomatic. So yeah, thank you very much. Let's make our holidays safe.
Thank you very much, Dr. Gasperowicz. I keep saying that the holidays are in the air, and so is COVID-19. So this week and next week, we are going to do a brief overview of those things again. That way folks at home can try to have the safest holiday season possible. So hopefully Alberta doesn't need to feel the 5th wave. I'm going to bring back up all of our panelists. That way we can continue this dive into the virus variants, what we do know, what we don't know. I'm going to turn things over to Dr. Vipond. That way we can continue the conversation that we began at the beginning around what is happening in sub-Saharan Africa, what we do know, what we don't know. Oh, there we go. Oh, Dr. Vipond, you are muted.
Yeah, I just wanted to clarify my thoughts because I think both Dr. Kelvin and Dr. Kindrachuk were rightly pointing out that we don't know a lot about this virus, and I want to echo that. But I also want to, because I've had family members actually come up to me with this thing called hopium. Hey, maybe this is the best thing that's ever happened to us. And I just want to say, whoa, like, let's slow down. Like, maybe we can have that conversation in 2 weeks when we know a lot more about this virus. But what we do know still remains concerning. Let's find out what's actually going on. And in the meantime, let's apply the precautionary principle. And I think we have, as a society, consistently failed in applying the precautionary principle, whether it's been on mitigation strategies or airborne precautions. So, just a call out for the precautionary principle. I think it's great that we've started to have some travel restrictions. I personally would love to have more of a, as Dr. Gasperowicz pointed out, a more of a quarantine on arrival style for all travelers here, because it's going to be coming in from all directions, not just from sub-Saharan Africa. And I think there is a little bit of maybe latent racism going on and just focusing on those countries rather than on other countries around the world. And I just wanted to say one other thing, and I think Dr. Gasperowicz also pointed this out. The principles of physics still apply to this variant, no matter what. It can't infect you if it can't get in you. And that means everything that we've been doing before will still work. And that's gathering restrictions and making sure that asymptomatic people aren't exposing themselves to others by doing rapid testing. And of course, really, really good masking. So maybe I'll just throw it back at the three doctors to see if there's any other thoughts on that.
Yeah, it's, I think certainly, bring up great points. I don't think we can move to this idea that, listen, if it has a lower virulence, that may actually be beneficial because then we can get everybody infected and move on. We have to appreciate that certainly. We can't look at this as being basically binary, where either it's virulent or it's not virulent. There's a gradient with all of this, right? So when we think about this idea that, is it more transmissible or less transmissible than Delta? We have to think about the fact that there are different variables at play. So you can have something that maybe is more transmissible, but a little bit less virulent, and still end up with a lot of people in hospital. And we have to appreciate this is not a uniquely Canadian epidemic or a North American epidemic. There are many areas of the world and many areas where Dr. Kelvin and myself are extremely familiar with from our work in the past and our travels in the past, that do not have either vaccine equity or healthcare infrastructure and sustainability to deal with with even a lesser or mild disease. It's going to result in a lot of cases. So I think for us, we have to look at this aspect that we have good tools right now to be able to try and mitigate severe disease, and that's in the vaccines that have been produced. We don't know how fully that the current vaccines will provide protection against severe disease against Omicron. But what I would also caution with this is that I think, again, the vaccines so far have stood up the test of time against the variants that have emerged. So it would be surprising to see Omicron emerge and completely subvert the vaccines. That is not going to happen. There may be some drop, but we have to appreciate as well that there are other mitigation measures as well that we could use. So certainly want to hear what Dr. Kelvin has to say as well.
Yeah, Jason, again, I echo your comments. I was really thinking about no new virus is no good no matter what. There is no spectrum of more pathogenic, less pathogenic, mild, severe. We look at influenza viruses. Influenza kills about 3,000 people per year in a typical season in Canada. So there's a spectrum of vulnerability, vulnerable populations that I think we all need to be aware of. And so a new variant is not going to be good no matter what the pathogenicity it has. But at the same time, we want to be taking in all the information we can to assess it and assess the transmissibility, assess how it may evade pre-existing immunity, either by infection or vaccination, and how severe and what the clinical picture is of this new variant.
Dr. Kelvin, can I, we're so lucky to have you on. I think you're our first vaccinologist that's on. Quite a debate in Canada over third doses, and I'm intentionally calling it a third dose and not a booster. I think there's more evidence that this is a 3-dose vaccine and not a 2-dose vaccine where you get a bit of extra on the third dose. But I'm just wondering, Omicron, irrespective of Omicron, where do you think we should be going for the rest of the population on third doses with this debate going on?
Yeah, I think so. Again, I'm not creating public health guidelines as well as how the vaccines should be administered, and I'm not a medical doctor, but my knowledge of vaccines is quite extensive. I am hesitant to give widespread third shots or boosters, knowing that there isn't clear evidence that in a healthy adult there is decreased immune protection as well as decreased immune memory. So at this time, I would be cautious. Now, looking at a new variant, that brings up a lot of new questions. Aside from that, I'm still very concerned, though, about people who would be over 65, as well as people in vulnerable populations. They for sure should be getting the third booster or the third shot. There's a lot of evidence to support that that's beneficial in those populations.
As our conversation today is focusing a lot around Omicron, I did not take ancient Greek. If we could roll back a little bit, just for folks at home, could someone give me a lay human explanation of virus evolution as it relates to SARS-CoV-2. My understanding is that the more transmission we allow, the more likely it is that the virus will have an opportunity to create new variants, some of which become variants of interest, some of which become variants of concern, some of which we don't worry ourselves about. What does that pattern of evolution look like in terms of, do we even know, is there a base denominator of 1,000 infections might equal one genetic chain? I have no idea, and I would love to.
I can take a quick stab at this. I don't know if Alyson wants to certainly add her thoughts. When we think about this idea of viral evolution, we certainly have to appreciate this is a very random process, right? So as somebody who kind of cut their eye teeth on bacteria and then moved into viruses, we often think about things like antimicrobial resistance and antibiotic resistance, and somewhat equate that to maybe what we see in regards to evolution of viruses and selective pressure. It's very different, right? We've considered the fact that bacteria have an active metabolism. They respond basically instantaneously to their environments in the same way that, or very similar ways that our own cells do. Viruses, we see that there are random mutations that will be generated because, in essence, the replication machinery of the viruses are sloppy, right? So the Microsoft Word document that gets generated and keeps producing copies upon itself, that spell check is not necessarily very good. Sometimes it's completely absent. In coronaviruses, it's there, but it's not, overly perfect or overly good even. So as those mutations start to generate, now we start to look at the aspects that go into changes within the virus. So can the virus be transmitted more readily? Is it able to bind to cells with a higher affinity? Is it able to counteract early immune responses? Is it able to replicate to a higher efficiency? And none of these things alone may actually be predictive of whether or not that new variant is going to be able to be sustained in the population. So we think about this idea of evolution. It's very random. It's occurring all the time. Variants are being generated throughout the course of infection because mutations occur, very frequently. But often these mutations are silent. And that's the important point that we have to kind of appreciate, is that variants are always present. So we think about this idea of variants of concern. Variants of concern represent a tiny fraction of the variants that are being generated. The unfortunate reality is that these have, the additional advantages to be able to proliferate quite a bit better than maybe what other variants in the population are, and they can get sustained transmission. So, all of that. What am I trying to say? It's a random process. This is part of what viruses do. The more that we let viruses transmit, the more we open that opportunity for viruses to continue change, and certainly to open up the opportunity for additional advantages in fitness of viruses to start to take over in the population.
Can I just follow up that thought, Dr. Kindrachuk, and it's for either of you virologists. Can this evolutionary process go infinitely? Like, it seems like the most transmissible item we have in the world is measles, which may have an R naught of somewhere between 12 and 20. And we're getting pretty close to that. Is there a theoretical upper limit? And kind of along with that, does the fact that there's asymptomatic transmission change the evolutionary pressures over something like SARS-CoV-1, where because it was easily identifiable as only being in symptomatic people, it was easily to get under control? So kind of a two-part question.
Alyson, I'll let you jump in if you'd like.
Well, I guess that goes back to how I think of the dynamics. I don't think that you can think of R naught as being static. It's dynamic in, your social situation, as well as your biological situation. So I think, it's an important thing to think about, but also know that the situation with the measles virus isn't the same as what we're looking at with SARS-CoV-2. In respect to evolution, I think Jason had some good points on what I consider to be barriers. There's certain barriers that a virus has to go through that's really going to weed out certain viral populations, and that becomes the selective pressure. So the virus has to get into the cell, so somehow it has to have that right makeup to actually get in. And once it's inside, then during its viral replication cycle, it's going to make mistakes, as Jason had mentioned. And then after those mistakes have been made, the mistakes have to be carried over into quality new virus particles. And typically we think of the virus particles coming out of an infected cell to actually be more of a population than a continuous almost copy of itself. So as it's leaving a cell, it goes through another barrier, and that's finding a new cell to infect and replicate again. And then we can think of the barriers that are throughout, in this case, the respiratory tract. So we have a barrier of where it's going to replicate in our bodies. Is it going to be in the upper respiratory tract in our nose, or in the lower respiratory tract in our lungs? And this is going to really start selecting what type of virus is going to be easily sneezed out or coughed out, and then also possibly the clinical symptoms that are going to be associated with that virus. And then the whole process starts all over again once this population of viruses go and find a new host, and is that new host able to be infected again in the upper respiratory tract or the lower? That's another barrier. So I think that, there's a lot of dynamic pieces even in that situation, but a lot of randomness in what the virus is actually doing and what mutations are taking hold within the virus.
Any thoughts from you on that, Jason? Sorry, Dr. Kindrachuk?
No, please just go with Jason. I
guess absolutely. It seems like there's different evolutionary pressures here than on your average virus. For some reason, we don't have variants of measles that are outcompeting vaccines. We don't have variants of measles that are getting more and more transmissible. Is there something unique about this virus that's allowing this to happen? And if so, what's the upper limit?
I don't know if there's anything that's specifically unique. Certainly we're seeing broad spread globally right now, which I think is one of the biggest aspects of this, right? So certainly we go back and say, okay, if you were to look at measles, say in the early 1900s, were there signs of a lot of variants that were being identified as measles was moving through the population because of the breadth of the number of people that were being infected? But we don't necessarily have that data, or at least that I know of. I think right now what we're seeing with SARS-CoV-2 is, listen, we're looking at obviously billions upon billions of infections, and that continue to move through populations and certainly move through different barriers. And the virus is really still stretching its legs, right? So there will be an upper limit. We have to think about the fact that there are fitness costs that come with some of these mutations as well. So, we have to appreciate that, there can be a lot of, I think, fluidity in how the virus is mutating. But there are also going to be costs that come with maybe over beneficial activities or function within particular mutations. And I think one of the things we are looking at right now, certainly with Omicron, is this question about all the mutations we're finding in spike. So, we're looking at 30 odd mutations within the spike protein. Now we can look at these individual mutations and we can say this particular activity is associated with these mutations or this constellation. We've seen this with other variants. But the thing we don't necessarily know is how all of these work in concert with one another. And I think, again, this goes back to this idea that we really have to take a step back and say, we don't know definitively what the behavior of Omicron is. We are going to figure it out, certainly in the next few weeks as we start to look at this as a global research community. But we can get some sense of that from the mutational profiles and the sequencing data. But we have to be able to look at the actual epidemiology data and certainly the biological data to say, do all of these activities or all these mutations lead to additive effects, or do we start to see that there are maybe cancellation effects that are taking place? And I think simply we don't really know at this point.
Yeah, I think, Jason, also it's an important point that this is a new virus to humans. I think right now we don't have a good sense of how fast it is mutating. It could just be adapting to people. And that's what we're seeing, these huge jumps in say mutations that are being conserved and allowing the virus to infect and continue transmitting.
The only other comment that I stand on in this is, we have to consider as well with SARS-CoV-2, which is one of the unfortunate realities from a One Health standpoint, is this is not a virus that is solely unique to humans either. And that's another aspect that we have to appreciate, is that, listen, as it's mutating and as it's changing, we're also starting to get a sense of where this virus has spilled over in animal populations. Certainly today we heard the announcement about the first positive samples or positive identification in deer in Canada, which we already knew was happening in the US. And certainly there are other animal species that we know are being infected. So, there are going to be different drivers within these different populations. And I think we are really learning right now what this looks like, and certainly what SARS-CoV-2 looks like from a health perspective in regards to spillovers from different animal species.
So I have a question to Dr. Kelvin. So do you know how the work on sterilizing vaccines looks like now? Is there anything on preparation? Because last year I thought that by this time in this year we would already have such a vaccine, and it would be such a game changer, right? It could stop. We
don't have a sterilizing vaccine for influenza.
I'm going to pop in for 1 second and ask what a sterilizing vaccine is for all of the humans like me at home who are just like, shoot me up with whatever you've got. That's going to make me safe. I don't know the difference.
Yeah, it's a great question, actually. Typically, we think of a sterilizing vaccine being a vaccine that induces antibodies that are able to completely neutralize the virus and block it from being able to infect new cells. So actually produce a productive infection in its host. We don't have that for influenza viruses. We didn't have it for coronaviruses before. The biggest problem with respiratory viruses is that there's a huge difference in our immune system between our lower respiratory tract and our upper respiratory tract, and then also how we are vaccinated. When we're vaccinated for flu and now COVID-19, we're vaccinated intramuscularly in our arm, and that really produces a good systemic immune response, which is going to protect our lower respiratory tract more efficiently than our upper respiratory tract, which is more governed by our mucosal immune system. So I think that to get something closer to a sterilizing vaccine, we would need a vaccine platform that actually sterilized our site of infection, which would be in our upper respiratory tract. So something closer to what we see with flu mist or the influenza nasal spray vaccine.
Thank you. So, because like a year ago, I read that there were works done on like nasal vaccines, and I don't know if it fizzled out or.
So far, none of them have been approved, and I'm not sure about the data for effectiveness and how they've done in phase 3 clinical trials.
Mm-hmm. Thank you very much.
So as we watch this variant of concern, and obviously more and more cases are being identified every minute now that folks are watching for it, before we say goodbye, could both of you, Dr. Kindrachuk, as well as Dr. Kelvin, as well as Dr. Vipond and Dr. Gasperowicz, if you want to weigh in, share just briefly what we do know about Omicron and what we don't know about Omicron.
Alyson, do you want to take this first, or would you rather I take it first?
You can go first.
I kind of thought that would be the thought. Listen, what do we know and what do we not know? There's a large chasm right now in regards to our knowledge on Omicron, right? And I think you've seen that play out on social media and in the news over the last 5 days, and certainly with people that have been doing COVID research for the better part of 2 years now. You've heard us, be very, very vocal, saying, listen, we need to be very centrist right now because we don't understand a lot about this variant of concern. What do we understand? It's emerged. Obviously, we don't specifically know where it emerged from. Thankfully, to our South African colleagues, again, we owe them a debt of gratitude, but they identified this very quickly. We've been able to get surveillance broadened out across the globe. We're identifying cases very quickly. But it also has put us a little bit behind the 8 ball, right? Because we've identified it before we've been able to actually start to understand what this variant of concern is. I think the best way for us to view this is some Delta is still putting a lot of people in hospital, still putting, unfortunately, a lot of people into ICUs, and unfortunately resulting in a lot of fatalities. We need to continue to deal with Delta. We need to be concerned about Omicron. We need to figure out what it's doing. We'll get a sense very quickly, but we have to appreciate that the things that we've been able to do in regards to mitigation measures are likely still going to be effective against Omicron. So I think we have to wait for the data to come in over the next few weeks. But we need to, to really try and figure out where it's moving in our communities, and certainly in areas where we're seeing high incidence of Omicron, we need to figure out how we can provide them, with additional resources or support to be able to get things under control. Understanding that increased transmission in other communities globally is going to have not only a health effect on us, but an economic effect moving forward as well.
I think it's fascinating that we're doing this backwards. Like for every other virus in the world, we've understood how it deals with human populations, and then we've gone as we've improved our science and figured out the molecular biology and the genetics and the DNA. This time we're going at it backwards, right? We understand the shape of the protein and the actual sequence of the genetic material, and we can even play in the lab with antibodies and see how it interacts with the spike protein. but we don't know what it means for populations, right? We don't know if you put it in a room of 1,000 people, how many people are going to walk out with an infection? How many people are going to wind up dead? How many people are going to wind up in the hospital? And what are the means we have to manage those? So I think it's really, really important to reiterate, there is so much we don't know. We don't know the virulence. We don't know the how it interacts with our immune antibodies, our body without any vaccines in it, and we don't know how transmissible it is from person to person. So what do we do know? We know, as Dr. Kindrachuk said, we know the mitigation measures will almost certainly work. If it can't get in you, it can infect you. And everything else is left to be seen.
Before we close what I know is going to be an ongoing topic of conversation over the coming weeks, I would love to close off this section with both Dr. Gasperowicz and Dr. Kelvin. What are you two going to be watching for over the next few weeks? So we've talked a little bit about what we do know and what we don't know about the new variant, but what are some of those positive and negative signs that, from your guys' expertise, you're going to be keeping your eyes on as more information becomes available?
So I will be definitely watching the number of cases and the rate of spread and how fast or slow it grows.
Yeah, so I guess I just want to address one thing about what we do know before I get into what I'll be watching, and that's that the vaccines that have been developed for COVID-19, the platforms that have been used induce both of our immune system's arms, so our antibodies or our humoral immune system, but also our T-cell immunity. And our T-cell immunity is really, really important because it actually induces a more cross-reactive or cross-protective response. So I think we're really lucky in that regard. And also to identify that we're in a very different situation than we were in January 2020, where we have some pre-existing immunity in the populations. People have vaccines, and they also, some people have been infected already. What I'm looking for right now is a number one experiment that I want to do is actually in the lab. I would love to have some Omicron virus and do virus neutralization assays and see if the antibodies that were elicited from vaccination or previous infections can block viral entry. So I think that's going to give us a huge insight into how severe this disease is going to be in people who are already infected or vaccinated. And as I mentioned, though, we also have the T-cell immune arm. So I would also be interested in stimulating T-cells from vaccinated people with peptides or pieces of the virus and see if we have cross-protective immunity. Looking on a population scale, I'm really looking for what type of breakthrough infections are happening and what type of reinfections are happening. So if you were vaccinated with AstraZeneca, are you more likely to be infected with Omicron compared to people who might have been vaccinated with Moderna, which we know has a slightly higher effectiveness compared to Pfizer and quite large compared to AstraZeneca for our regular variants. So I'll be looking for that and parsing out specifically where the cases are. And yeah, I think some other important points that were mentioned too. What is our caseload and where is it located throughout the world?
Thank you all so very much for your time today. As always, this topic is way too large to discuss in an hour and take all of the questions that we were receiving via the social medias. Your insight has been exceptionally valuable, and I am looking forward to continuing to access that insight via your guys' online profiles as we learn more and more about this new variant of concern and continue to try to keep the variants of concern that we already have circulating freely in our communities under control. Before we say goodbye today, we are going to bring on our final panelist. I have a very special guest that I have been looking forward to all day to talk to. This is my friend that I am just meeting in the digital space for the first time, Eleanor. Hi, Eleanor. I'm Michelle.
Hi.
Hi. Could you introduce yourself for the folks who are watching?
So my name's Eleanor, and I'm just here to talk a little bit about kids' COVID shots.
I really appreciate that. You see, I've been looking for an expert on kids' COVID vaccines, an expert who had a kids' COVID vaccine and could maybe talk to some of the tiny humans who haven't had one yet about what it was like. Could you tell me a little bit about what happened when you got your vaccine?
Well, yeah, it was really short, and yeah, I barely felt anything. And it was about like 1.5 seconds. It was super short.
What was the place like where you went for it?
It was busy, but there's like barely a line though.
Oh, that's handy. So it seemed like there were lots of other not so tiny humans getting their vaccines too?
Yeah.
Yeah? Was it a pretty big place?
Yeah, it was pretty big.
So there wasn't too much of a line, but there was a line. Yeah? And so then after you got in the line, what happened? Just so people know what to expect.
Well, there was like you had to like sign some things and you had to do your signature and like you just fill out some papers and yeah.
So you filled out the papers, and then did they take you to another spot to give you your vaccine?
Yeah, kind of like a little room without a door.
Okay. And did they put it in your tongue?
No, they put it
No. Okay. Where did they put it, Eleanor?
kind of like on your shoulder.
Okay. Were you wearing short sleeve or long sleeve?
Short sleeve.
Did that make it easier?
Yeah.
Yeah. And you said it was like 1.5 seconds?
Yeah.
Oh, that's pretty fast.
Yeah.
And then what happened after it was done?
Well, sometimes it feels sore if you don't move your arm around for a while. So it's really good to move your arm once you get your COVID vaccine.
That makes sense. Do you have any other tips for other tiny humans who are going this week?
Well, some things that you could do is you could bring headphones to listen to some music or watch a movie, or like hold a grown-up's hand and think happy thoughts.
That is exceptionally smart. And you'd already mentioned that you were wearing short sleeve, which seemed like it made it easier.
Yeah.
So headphones or some sort of movie. You mentioned moving your arm a lot so that you didn't get stiff. Did you do anything else when you got home to help make you feel comfortable and safe?
Well, not really.
I've heard that some people like putting ice on their arms afterwards. Any thoughts on that? Did you need it? No? Yes?
No, not really.
No? I think that you must be much stronger than I am, because I know that I needed some ice afterwards. This is really quite impressive. And so when do you go for your second one?
When I'm not sure yet.
That's fair. That's fair. Did you have any side effects afterwards? Like you didn't need ice, you kept moving your arm. I know some people say that sometimes they might feel a little bit sick after. Anything like that?
No.
This is really, really exciting to hear. So if you had sort of a final thought to give anybody else who's in that 5 to 11 sort of age range about getting their first dose of the COVID vaccine, what would you really want them to know?
Well, it's like just really try not to panic because it's just really short.
Excellent. I love it. Don't worry about it. It is really short, over and done with before you know it. And how do you feel? Do you feel safer like in going to school? How do you feel?
Well, I feel like now I only have one more to do instead of 2 more COVID shots to do.
That is excellent advice. As soon as you get one done, hopefully you've only got one more to go. But you're partway through.
Yeah.
Oh, this is great. Great. Anything else that you would like to share with everybody before we say goodbye for today?
No, not really.
Well, thank you so very much, Eleanor, for agreeing to come on and talk to me a little bit about what it was like for you to get your vaccination. And congratulations.
Yeah.
Yeah. Thank you so much.
Yeah, thanks to you too.
Oh, thank you again for thanking me. Lovely. It's just great. Should you say hi, Mom, and like wave out into the universe? Thank you very much, Eleanor. So thanks again, everyone, for tuning in. We're going to continue with our every second week format, and we're going to take that little bit of a hiatus towards the end of December. But as always, if something needs to be highlighted, we will make sure to do it in a timely fashion. So please make sure you are subscribing in whatever format you are usually joining us to be notified in case Pop Alberta needs to pop up prior to our next scheduled briefing, which currently is slated to be Wednesday, December 14th, 2021. Once again, thank you so much to all of our panelists who joined us today, our extra special guest, Eleanor, as well as everyone watching in whatever fashion you tune in. Until next time, stay safe, Alberta. And as always, remember, COVID-19 is airborne. Wear the best mask you have access to, and vaccines really do save lives. Thank you so much, and we will see you again in a couple weeks.